Welcome to Orthopod, a podcast about the people of orthopedics and their stories. We understand that we all play many roles in our careers and lives, and it is these very stories that ultimately inform our successes and failures. Hi, everyone. Welcome to another episode of Orthopod. My name is Mo Bendari. I'm editor-in-chief of Ortho Evidence, and from time to time, I get the opportunity to talk about some what I consider to be genuinely important milestone projects that happen. Today is just one of those moments. I'm here with Professor Matt Costa, a longtime colleague and friend, and we'll get into that shortly, but he is from the Oxford group, the Oxford Trauma and Emergency Medicine group, and has been, I guess, a trailblazer in large clinical trials. And so we have lots of things to chat about, but today we're here about a recent New England Journal of Medicine paper. I believe it came out February 10th of this year, under the title of Cemented or Uncemented Hemi-Athroplasty for Intracapsular Hip Fractures. Welcome, Matt, and delighted to have you share the results and some of your take on this particular paper with us today.
Yeah, thanks, Mel. Well, thank you for inviting me along. I'm a big fan of this series, regular listener, so it's a pleasure to be here.
Yeah, so tell us a little bit about the key messages from this study, and maybe and a bit about the history. Like, how did it come to be, and what did you find?
Sure. So, I mean, it's over 10 years ago now that the Cochrane group, a colleague of mine, Martin Parker, wrote up the evidence about cement, bone cement for the use in hemiarthroplasty for hip fracture versus uncemented implants. And at the time of that review, most of the evidence came from the very first generation of uncemented implants, the sort of things that you and I will just about remember. Austin Moore's and uncemented Thompson's, where it was basically a bit of metal that you wedged into the top of the femur and hope for the best. And the Cochrane review showed very clearly that the cemented implants, the bone cement used as a grout to fix the implant to the femur, did better, so less pain and better outcomes generally. And so in many countries, including the UK, most of us started using bone cement as the default for all of the patients having a hemiarthroplasty for a hip fracture. But of late, there's been a move, a lot in North America, but not other places around the world, and increasingly in the UK as well, to start using the modern uncemented implants, the sort of thing that have been used for many years successfully for treating patients with arthritis for hip replacements, but using them for hemiarthroplasty for patients with hip fracture. And given that trend seemed to be accelerating, we thought we'd better do a study comparing modern uncemented implants with those fixed with bone cement. So as usual with these projects, we reviewed the literature, and there were 2 or 3 trials beforehand, but smaller studies, 100 or 200 patients, that we didn't think really nailed the question. So following your usual advice, we went large and just did a bigger study to a randomized trial to compare these 2 implants. So that's the background to the project, and of course 5 years later you get a result.
Yeah, so let me ask you this. I suspect some of our listeners and viewers already know the answer. They've read the paper, but probably many haven't yet gotten to it. So this will be news to them, which is great. But you build a story just like we did. We did it multiple times where prior smaller studies using different implants, for example, come up with a very large treatment effects favoring something. When you went into this trial, were you believing that we're probably going to see and confirm the hypothesis that even against modern day uncemented, cemented's probably still going to be the hypothesis that it's better? Or did you go in with the mindset of truly it could turn out that there's no difference between the 2?
So it's a good question. So I always, I like to think I always have sort of equipoise about these issues. So we'd only do a trial if I really was uncertain about the outcome. Yeah. But the truth of the matter is, I, like every other orthopedic trauma surgeon, I have an opinion about this, and I'm, a strongly held opinion, personal opinion.
Right.
And so I thought that we'd probably end up with a trial that showed that there was little difference in terms of the outcomes, but probably a big cost difference, was my suggestion. But what I've learned over doing this sort of job for quite a while is that normally when I guess wrong. You think it'd be 50-50, but it's not in my hands. I very seldom guess right. So I've almost given up suggesting really, but I didn't think we'd show huge differences in quality of life.
Got it. And you got it. And that totally makes sense to me too. Like, and when you do something much more rigorous, Everything kind of always seems to be, in my mind, it just seems to get closer and closer to the null. But the thing that was interesting too is, like, we've sold prior to selling, meaning the idea of why we need this study. It's very difficult, I've found, and maybe you have this idea. Before we get to the results, I'm keeping people in suspense here, as you can see here, Matt. But about this issue of equipoise at an individual level, I must say I've gone into most of the studies I've done with the general belief that I think something is better and have an hypothesis. But the truth is, when we look at our whole trial group, and or what's happening around the world, there's generally equipoise, because there are strong, ardent advocates, let's say in North America, for uncemented, for an example, or popularity, and maybe strong, ardent advocates for cemented approaches in Europe. So globally, there really isn't an answer, even though individuals feel they have the answer. And I wonder if that has been more of a pervasive around all the programs you're doing, including this one.
I think that's absolutely right. In theory, you should always have personal equipoise when you're, enrolling patients into randomized trials, but I'm pretty sure that doesn't exist these days. I mean, and certainly not in surgeons. I mean, we all have a view, and you kind of need a view in order to perform your practice day to day. You've got to have faith in what you're doing and believe on behalf of your patient you're going to get the best outcome. So I've kind of given up on individual equipoise, really. But I think that's fine, because as you quite rightly say, as a community of surgeons, in countries all over the world, we don't know, and we actually, although we've all got our individual opinion, they're usually diametrically opposed, as you suggested.
Absolutely, I know that storyline. Okay, so you had shown, well, prior Cochrane reviews had shown that there's a potential, and if I recall, that benefit was not a minor; it was a fairly significant benefit demonstrated. You had suggested let's do a large clinical trial, multi-center, rigorous as you always do. Thinking that, okay, let's see if we can either prove or disprove this hypothesis. So tell us what you found.
So, the really important thing is that all of the implants used were the modern, the most up-to-date generation of uncemented implants, as well as the modern cemented ones as well. So it was different from the previous sort of studies. So the main finding, which slightly caught me by surprise, we showed a small but statistically significant improvement in quality of life for patients with this cemented implant. So that was the key finding. The primary outcome measure was health-related quality of life as reported by the patients themselves. And we showed a definite improvement at 1 month, at 4 months, which was primary endpoints, but a much smaller difference at 1 year. We can talk about why that is, but obviously a lot of these patients are very frail, and the mortality rate's around 25%, so you lose power as you go on. So an early benefit in terms of quality of life, and then a much reduced benefit at 1 year was the headline from this.
And were there any other outcomes of interest?
Yeah, so the key secondary, the outcomes, which are all reported in the paper, the clinical ones are, was really around periprosthetic fracture, because if you are taking a bone, which is almost by definition osteoporotic because of the nature of this injury, and you hammer a metal implant into it, the worry is about periprosthetic fracture. And we showed that was a statistically significant difference. There were more periprosthetic fractures in the uncemented group than the cemented group. That was the key secondary outcome finding. We've shown benefits, smaller benefits in terms of mobility and so on in favour of the cemented implant as well. But they were the key headlines, really. Lower periprosthetic fracture rate and improved quality of life with the cemented implants. And the thing
now, did you get to go ahead. Sorry, I was going to say, did you get to a mortality signal in that?
We did report mortality, and the intention treating analysis, primary analysis, shows no difference. But I think it was 27% in the cemented group and about 23, in the uncemented group, and about 23 in the cemented group. On the per patient, on the per protocol, so according to which implant the patient actually had, because there's always a few crossovers in these studies, then actually there is a statistically significant reduction in mortality in the group having the bone cement, which is interesting. What we couldn't do in this study was look at the early mortality. So this sort of bone cement implantation syndrome, that's always a big concern. It was one of the drivers for the trial, really, that worry about people having terrible reactions to bone cement. And of course, to answer that question, because the event rate's so low, you need a different type of study, really, and registry work, which has been done elsewhere in recent papers on that.
It's funny because not funny at all, but it is the reality. What we've been seeing is, and that I guess is always the way, right? Like the trial answers
this trial definitely takes us forward a big step, right, in understanding this problem. And yet some of those that are convinced that that it didn't go far enough. We found that with our health trial where we had 2-year outcomes showing no difference, and then suddenly between total hip and hemi-arthroplasty, but then the advocates were saying, well, you didn't wait long enough, and if you waited long enough, we would start seeing the benefit of total hip, and probably to some degree, there's quite a bit of validity in that. With the mortality issue, I'm sure you're aware, as many of us are aware, that there've been a number of large database studies that have come out that saying that the issue with uncemented having increased periprosthetic fractures may in fact itself be with enough patients a driver of potential signals in mortality. So in some way, we might even start looking at the periprosthetic as a surrogate potential for real concern. I mean, a signal that in large numbers could be. Do you believe that's also the case? Do you believe that if you had sufficiently more patients and that you may have in fact seen that signal, the impact of the periprosthetic fracture and mortality?
Yeah, I mean, quite possibly. So if you're looking for those rare adverse events, then of course, you're looking at randomizing tens of thousands of patients. We've tried to do that with infection, which is a bit more common than death. And even then we're struggling, even with we just finished a 5,000 patient trial, and it's still not enough really, if we're absolutely honest. So it's huge numbers. So you've really got to go to registry data, which is of course non-randomized, but you can do, well, as you've shown many times, you can do some fairly good analysis based on that with big numbers. And the Scandinavians are great at this. And they published a paper recently, actually in the Bone and Joint Journal, which I think really is the strongest evidence I've seen yet to say that there is a real effect at 1-day mortality. There's a slightly higher rate of mortality in the group having bone cement, but actually by 7 days that disappears. And the trend at 1 year is towards lower mortality in the cemented group, as we found in this trial data. So I think there is a definite effect of bone cement on perioperative mortality, but it's really rare. The adverse events are relatively common, around 1.5%, but actually death is very rare. But that equalizes out by 7 days. So within the first week, there's no difference. So
that's right. Yeah.
For me, that's strong evidence towards, still saying, yes, there's a real effect here. We need to acknowledge that. But actually, there's still an overall benefit to cementing the hemi-arthroplasty, was my interpretation of those data.
Got it. So has practice then, from your perspective, changed at your institution or the participating institutions now? Is it pretty clear, or about what needs to be done? And in terms of your message, when people say, okay, based on this paper, what is your recommendation? It seems pretty clear from the paper's findings, but just maybe to hear it from you.
So we're recommending using the cemented hemi-arthroplasty as the standard of care, really. And the other piece of the jigsaw, which is the cost. So we did a full health economic analysis. It's interesting, a lot of the large American journals, New England Journal being top of the pile, don't necessarily want to publish the health economic side of things. And there's lots of reasons for that, which we could go into another time. But it's really important, particularly in the UK, where, as you know, we've got a national, a single healthcare provider, our National Health Service, and so containing costs is pretty important. So we did the economic analysis, and slight spoiler alert, it's actually cheaper to use the cemented implant as well. So if you've got lower complications, better quality of life, and it's cheaper, then that, to my mind, is a bit of a no-brainer. We should be cementing these implants. Having said that, I recognise there's some training issues and other factors involved, but in terms of the future for people being trained now in orthopedics, we should probably be teaching these cemented techniques, which are not difficult. It's it's a relatively straightforward thing to do once you're familiar with the bone cement.
That's very, very cool. Maybe just on a personal note, I don't know if you recall, Matt, the first time you and I actually met, but I recall, in reflecting on this paper, that I think it was in 2010 at a combined meeting of the orthopedic associations. I think it was in Glasgow. And I remember being at some small venue where there's like 4 people, and Damian Griffin came in and said, "Hey, I want you to meet this, this person." I said, "Yeah, sure." And I was with Emil Shemich at that time. You may or may not remember this, but I remember it now,
yes.
reflecting back. Yeah. And, at that time, and he made a point out, and that stuck with me. He said, this guy's going to do big things in research, right? and it's kind of the way that I remember maybe a decade before I had been introduced to somebody else, to a Mark Swinkowski or Paul Trinetta or Emil Shemich, these folks. And I guess when I look back, I was kind of smiling when I saw this paper, only because, I saw the paper. I said, "Hey, have you heard the New England?" I said, "Oh, yeah." I looked at it and I looked at the first author, and I went back and said, "Oh, this is awesome." Like, I don't know if this is your first, maybe you've had many prior New Englands, but the point is there is something like a milestone about in a career. When you get to a point where you have research that is disseminated far beyond the orthopedic world. I think this type of research you're doing and the work you're doing has transcended our subspecialty in many ways. And I think there's something, I don't know, I hope you take a moment to reflect back on the team, right? It's right now you and I are talking, but I know there are hundreds of supporting members and collaborators with you that I know you would acknowledge and and I'm sure you put them in front, because I just know the type of person you are. But anyways, I just wonder, have you taken a pause to kind of reflect on what this means for you, and not so much the paper per se, but the journey to get here?
Yeah, absolutely. I do. I remember that meeting very well. And I mean, we talked about this before, but we in the UK, we copied what you did in Canada. I mean, unashamedly. So the COTS movement to decide what questions the community wanted to answer rather than individuals, and then to work together to do that, was something we blatantly copied from what you did in Canada. And fortunately, having a single healthcare system in the UK, single healthcare provider in the UK, I mean, there's pros and cons of that sort of thing. But one thing it does facilitate is collaborative research, and so we set copying what you did from Canada in the UK. And to my amazement, and still to my genuine delight, my colleagues around the country seem to get on board with this. And now we actually went from, how it was when we first started, you had to go around begging people.
Oh yeah, I know. Oh yeah, well, exactly that feeling. Yep.
Corruption, whatever worked, it was that we needed help. Now we have queues of people. Sometimes we can't open all the centres that want to take part, which is just brilliant. It's fantastic, and that changed in people's mindsets in the UK and Canada, and increasingly other countries around the world as well. Is just the biggest pleasure in my career today to see that transformation. And you're absolutely right. The collaborating authors list is very long on that paper, but so important, because it's, you and I sit there and write bits of paper, and I operated on a handful of the patients, but the collaboration involves hundreds of surgeons in different centres, and without them, of course, it just doesn't happen. So they're hugely important. In fact, they're the most important thing about the trial. I know. I mentioned the research nurses who collect the data.
Absolutely,
they're probably even more important. So they're unsung heroes, those guys.
For sure, and I know you feel very strongly about a team effort. It is about the team. In some ways we just function as sort of the spokespeople among I'm sure there's lots of spokespeople talking about this trial. I'm sure lots will continue talking about it. But from the perspective of you very kindly and multiple times have said what happened in Canada as this collaborative effort under a national healthcare system too, that I think in some ways, and also probably our size, right? Our size, it made it quite mandatory that for us to be able to do large trials, we'd have to work together. And in many ways, there's just a collaborative spirit that's developed over decades in Canada. But the thing that I think that differentiates and that makes me feel particularly proud of when I see papers coming up from groups and individuals I've known for many years, isn't so much that that they've done what we've done, but they've taken what we've done, they've improved upon it, and they're on a pathway to do things that we never did. And when I look at the kind of the work that's happening, some of the work around platform trials that have come out of Oxford, the idea that we can and having really a committed group of investigators, finding partnerships with the government that really are sustainable for large programs, and pushing the envelope, I think are all things that in many ways, when I look at my own career, I wish we would have had those, some of those built in, because there's a fatigue associated with large trials. And I think when you're the recipient of it, you say, oh, well, they should have done this, you should have done that. But, it's 10 years of your life getting to where you've gotten to for the one particular trial. So it's very easy for others to criticize outside, or I don't say criticize, but, they give constructive feedback. But unless you've done it and lived it, it's a different world.
Yeah, and that constructive feedback is incredibly valuable. I mean, there's not a single study trial I've ever done. I probably feel the same, where I wouldn't have changed something about it, wouldn't have done something differently if I had my time again. I mean, one or two of them I would never have started if I'd known how it was going to end up. So you always learn, and the criticism is key, because without the criticism, you don't improve for next time. But I think it's really exciting times for the research at the moment. So the White 5 trial was one of the last ones we did using the old framework of, we had a large observational study of hip fractures in the UK and used that as a sampling framework for trials. But we've just opened the first 2 randomized comparisons within a platform trial now in the UK. So I don't want to bore your listeners too much.
But I think it's important, Matt, because I think the reality is that what the methodology of how we get information out has been rapidly changed during COVID, and this idea of having a simple platform where you can bring product treatments in and out quickly, and comparisons in and out, that's the future. And I think we're gonna have to start seeing groups lead that, so we can then model that.
Totally. And so the World Hip Trauma Evaluation is slightly grand title for White, is the platform is one trial, and we're now running just about to open our 5th and 6th randomized comparisons within, so same multiple comparisons within the same participant group, and it's just so much more efficient. So yeah, there's lots of learning from, well, there's not much good about this pandemic business really, but one of the things that has changed is that acceleration of actually, it's the governance rather than the ideas. The ideas have been around for a while, but the approvals process and the governance structure to deliver those multiple randomized comparisons within one trial is a massive step forward. I'm really excited about it. It's going to, I think, transform how quickly we can deliver results.
That's great. I can't thank you enough. And maybe on my last question to you, it's more just for you to, again, to reflect and think about it. But when you look now to the future, some of these trials take some time, and it looks like you're on your pathway again for probably another decade worth of trials before they close out and you'll have results. Where do you think things will be in the future, and where do you think you're heading with respect to this program? I know we're talking right now about platform, but platform is just, again, randomized clinical trials as our core source of how we get information. Do you see yourself evolving to something even different as time goes on? And maybe you're already thinking about that.
Yeah, so I mean, the truth is, so I think these things are important. Obviously, you and I wouldn't spend a lot of our time delivering trials in developed healthcare economies if we didn't think they were important. But we're in some ways, we're kind of tinkering around the edges, really. Changing the surgery, you're probably better off using a simple technique and performing it well and avoiding complications than trying to develop incremental improvements in implant design for Hemi-Athroplasty for this group of patients. I think where the big wins will be are in low middle income countries around the world, and you've done this already. And we've been experimenting for a few years now, trying to create the collaborative relationships to make this happen in other settings. And probably the big wins I would have thought are actually in systems of care and pathways of care rather than in implants or bits of surgery. And as a surgeon, it slightly pains me to admit that, but we're probably not the most important person in looking after the older, frailer group of patients with fragility fractures. There's a whole team, as you alluded to quite rightly, there's a clinical team you need for that. It's not really about the surgery too much. And that's where I think we'll go in the future.
Absolutely. Yeah. I think, the majority of trials we've run have always come narrower and narrower, with suggesting that when you're looking at treatment A versus treatment B, generally speaking, if they've been utilized by surgeons around the world, they're generally, when done properly and carefully and safely, more closer than being further apart. Because usually, through practice and thing, you kind of figure out this isn't working, I'm switching to something that's working. And you're right, maybe the next innovation, in my mind, I think where you and I are aligning on some of these things, I've been independently thinking about it. I do think that some of the big innovations are going to come in the perioperative range. Now, where it is, how that whole care pathway for most problems, and hip fractures being particularly important, is, I think, going to be where we'll see some innovations. And we'll see if we're right on this, but I'm starting to see most of the hip fracture world aligning on interdisciplinary collaboration. This trial is a classic example of that, but let's not undermine the importance of this particular, practice changing trial. So huge congratulations, Matt, and the team. all of you who have been just representing orthopedics, but ultimately healthcare in the highest possible standard. So on a personal note, grateful to have you on and so excited for this study for you.
Oh, very, very kind of you, Mo. It's a pleasure. And I know the team are very grateful as well. And I'd say big fan of Ortho Evidence in the podcast, and we'll continue to listen in the UK and I know around the world.
Awesome. We'll disseminate this widely. Thanks so much.
Thanks very much, Matt.